District and Craven, and it's amazing to see so many colleagues joining. So welcome. I am Sohail Abbas. I'm Director of Population Health and Inequalities, and I will be chairing this session. We have 5 sessions planned over the week, so Monday to Friday, 1 hour each, virtual sessions to discuss our learning and journey of Core 20 plus 5 in Bradford District and Craven. So it's good. People are typing. If colleagues can type name and organization in the chat, and please put yourself on mute if you're not talking. We'll be recording the session. So if you don't want to be on camera, please turn your camera off. And there will be an opportunity to ask speakers your questions at the end. So have a think about it. And you can also post the questions in the chat. So a little bit around the Bradford District and Craven Core 20 plus 5. So Core 20 plus 5, quite a lot of colleagues know already. It's a national health inequalities improvement program launched by NHS England about 3 years ago in 2021-22. And we know that nationally there is really stark difference in the healthy life, the life that people live without illness between the most deprived and most affluent areas. And in Bradford District and Craven, that gap is around 20 years. And also what we call the premature mortality, or the difference in the life expectancy, or how long people live, that is also almost 9 to 10 years between most affluent and most deprived areas. So this Core 20 plus 5 approach was a national attempt to address those health inequalities. It defines a population, which is Core 20, and the Core 20 is the 20% people living in 20% most deprived parts of England. And in Bradford District and Craven, our most 20% most deprived areas of the district. And then there are some plus groups. What we say, they are high in needs and small in number. And we will be discussing those groups as our week goes on. And then there were 5 focused clinical areas such as maternity, health, respiratory health, early cancer diagnosis, cardiovascular health, for example, in the National Core 20 plus 5 program. So we will be presenting our work in Bradford District and Craven, how we worked closely with our 13 community partnerships, aligning the priorities to our locally determined plans to reduce inequalities. And it's highlighting what is working well in our approach. We will be sharing learning, celebrating what has been achieved in just 2 to 3 years of this work. And we want to support everyone to apply this learning in your own areas of work. And we will be posting a link in the chat. Sophie is going to post a link in the chat if you would like to join others of our 5 sessions this week. And please also encourage other colleagues to join. And it's a good time. We are going through quite significant change. We know about the 3 shifts of the government. We know about the treatment to prevention and hospital to community shifts, and a lot of Core 20 work that we have done is related to these shifts and the 10-year plan. So it's a good time that we take this learning. It's a journey. It's the journey we started with Reducing Inequalities in Community program, RIC in Bradford District and Craven. It's a journey that led us to Bradford District and Craven Core 20 plus 5, and we just want to continue this journey into the next bit of our quest to reduce health inequalities in terms of integrated neighborhood health and the 3 shifts. So I am delighted and excited to be joined by Professor Durga Duggal, who is the CEO, the chair, the founder of Center of Population Health, and she will be talking to us about some national picture and the work the Center of Population Health is doing. We have Therese Patron, our Chief Executive of Bradford District and Craven Foundation Trust and our Accountable Officer of Bradford District and Craven ICB. And we have Joe, who is our Reducing Inequalities lead and has been leading the Core 20 plus 5 work locally in the past 3 years. So I will now welcome our first speaker, and I will hand over to Derka Duggal to give us some national perspective.
Thank you, Sahel, and Duncan and the whole team and Sophie for inviting me. I feel really lucky to join you, though. I feel a bit of a fraud, kind of, I always come here and when I'm working with local leaders think, actually, I want to listen. So I'm really glad that there's other colleagues who are going to share insights about what you're doing locally. So I guess I've got some slides I will share, unless, Sophie, you wanted to. Shall I?
Might be easy for you to do, Dirk.
Yeah,
happy for you to.
Perfect. So there we go. I guess I'll canter through these slides, but I guess more than the slides, it was just to basically say, I think I met Sahel in 2018, maybe a bit before, and I was so moved by the work that you are doing locally in terms of Bradford District and Craven, and the wider, at that point, the West Yorkshire and Harrogate system, in an area which has stark inequalities, but your leadership locally led you to build a programme of work that over time, I know it feels tricky doing the work, but has actually stuck over time to be grown in a way that I think is really impressive. Rick is one that Sahel mentioned, but so many other things, the Doula Project and more. And I guess, so for me, it's as we move into hyperlocal, the key thing is also to remember what role you have already played and will continue to play in terms of supporting the national thinking. And I think that may be why I'm here. I have the great privilege of working with Sahel at the Centre for Population Health. And last year, it's because I think that your area is so fantastic that actually we held our first ever conference with local partners in Bradford District and Craven area. And what a joy that was in terms of talking about tackling health inequalities work. So I guess we'll share the slides, but kind of there's information about me in the slide set. I've got several roles, but I'm here in the capacity of working for the Centre for Population Health. We are a think tank, a relatively new think tank, but what we do is we really work to support leaders on the ground, support systems on the ground in terms of implementing approaches, as well as convening colleagues, because what we hear is it's a really difficult space to work, even in line with the shifts, but especially when we're trying to tackle health inequalities. And that is, the challenges of working cross-sector or bringing in community voice, keeping it high on the agenda, or thinking, what do we each do practically? We have a conference happening later this year. I'll put the link in the chat. If anyone wants to join, please, you'd be very, very welcome. And if anyone wants bursaries and stuff, just email me, because, keen to get it to reach anyone who wants to come. But, I guess a few headlines about what I think about the national picture. So I guess the national picture in terms of the shifts, I think are right. And I'll say why in a second. But these are the kind of charts that often come, often from an acute, often from an NHS perspective, that seems to be driving the kind of governmental the shifts and priorities. In some ways, I think, is that's not really showing an understanding about why these shifts are really needed. But on the other hand, it's exactly why we have the media headlines that we have, because there's been not enough focus on prevention, on tackling inequalities, on working really, truly cross-system and putting people and staff at the heart of our efforts. So on the other hand, glass half full, I think, well, actually, it does help that we've got it on the agenda. Health inequalities, I think there has been fantastic work over the years. The Core20PLUS5 is one of them. I think where there was this embedded from national, and real credit to Professor Bola Owolabi and her team in terms of Core20, it means some of these stark figures actually were given profile, but also a framework where we could take local action. I am worried that now, through the 10-year plan and other things, that notion of health inequalities, there's a risk of diluting it and not having a dedicated core focus. Of course, it needs to be part of everything that we do, and everyone has a part to play. And yet there is something about making sure, therefore, especially places like yours, keep shining the light, keep saying we need to keep focusing on this. For me, we've been talking about those 4 shifts for some time, but in a slightly different way. But that move to kind of, community focus, prevention focus, whole system focus, equity focus. So it does align well. My worry, like I said, is there's 3 shifts that the government talks about. I think we need to always keep in mind the 4th, which is not assuming that in our efforts things will actually drive equity, because we know from the data that the risk is it will widen. But actually that notion of proactively tackling inequality and increasingly thinking about ED&I and inequality, and thinking about community cohesion, workforce well-being, celebrating diversity, as well as tackling inequality. Not either or, but both and. It's a tricky space, and it's being sensitive to the impact that's having on our staff and communities, but also why it's so important that you're doing the work that you're doing. I guess the landscape changes and challenges. How am I seeing this? It is a system under pressure. I sit on the board of 2 NHS trusts, and there is no getting away from it, that whichever part of the system that we are part of, whether it's voluntary sector, in the community, within the councils, in the public health teams, the ICBs, national or NHS or otherwise, it's a tricky place, isn't it? But I'm a great believer that in the midst of challenge, in the midst of change, that's where opportunity lies as well. And that's where us as leaders, we need to step in and keep doing the work that you're doing. And that's why today is so important. I think there's huge opportunities in terms of the neighbourhood health guidance, the model ICB region, the political shifts, the changes in terms of CQC leadership, the 10-year plan. Whilst there is uncertainty, and I hear it a lot in the work that I'm doing, and people almost waiting for guidance, what I love about what you have always done locally is gone, no, we're going to start with the people, we're going to start with local needs, because that has not changed. If anything, there's more need to focus on this, and you've kept going. And I think that's what actually others can learn from. So please don't stop doing what you're doing. I think there's also exciting advances in terms of technology and other things. I guess I'm going to quickly flick through some learning that I think is helpful. So I'm not going to go through in depth, but I guess just to challenge ourselves, if we were going to go deeper in terms of thinking about inequalities, is also to think about existing tools that we take for granted. So, for example, these height and weight charts, or the Eat Well plate, how culturally tailored are they really? And I know you've done fantastic work on this, but what about the other tools that exist that we take for granted that are actually fit for purpose? Here, similar in terms of height and weight and the links, the risks to diabetes. What about how we train our future workforce? What are we doing that yet needs to kind of go deeper in terms of the inequalities? So, for example, the neonatal jaundice, and actually now the thinking that trained our future workforce initially was not diverse. The tools that we were using, like I said earlier, wasn't necessarily fit for purpose. But then what about what we're developing now that is going to be the tools of the future? So what about the things that we're developing in terms of apps? How equitable are they? What about the trials that we're doing when we're thinking about genomics and precision medicine? Because Race and Health Observatory are saying that the cohorts are still not based on equitable thinking and design. What about the lessons we've learned from the past, and how much do we keep them in our minds to inform what we are doing, continuing to go forward in terms of how we clad our buildings, or how we equip our staff, how we plan for the next pandemic? Indeed, how we are building a workforce that actually has representation at every level. When you look around on your boards, is it equitable? When you're looking at people who are developing transformation plans, are they using the learning from Core20? If not, I guess, how do we take that to the next level? So how are we doing the training? And there are examples I've put here, but I've only chosen to put other ones because your one I think is fantastic. So I could put it in all of those, and we're going to talk about yours. What about your Population Health Academy? So I had the great pleasure of working with yourselves, but what can you learn from the other academies to keep growing your efforts, both in terms of the work they've done, but also sharing yours? But what about the challenges they're facing? Because some of them are facing quite immense pressures to row back on that important work. How are you using the evidence base locally, but also some of the Core20+5 nationally? And I suspect you are. So how are you sharing your learning beyond just today? I'd be interested to hear, because I bet you've got absolutely tons. But to actually inform the thinking at the senior most levels, because I think that's where it's needed. So for example, how is your thinking, your insights actually shaping what's happening right now in terms of the thinking about building the next structures in DHSC, for example, and the thinking at that level about implementation of the 10-year plan? Finally, the work that you're doing in terms of community. One, I'd love to know in terms of the charities and organisations that you've linked to. When we came last year, we heard about a fantastic, rich plethora of organisations that worked locally. I'm sure that they've been connected into your Core20+5, but nationally the story is not the same. So in terms of funding, in terms of commissioning, there's a real need to actually think about how do we build this in so it's not just locally, but across the country. We are actually thinking about building community in much, much more strongly. And what do you need to do to advocate for that? So basically, I guess that's all I wanted to say was I feel absolutely privileged to be with you today. Thank you for giving me a short window just to run through some thoughts. But the key thing is I think you're doing absolutely fantastic work. I'm excited to hear more. And I can't wait to hear the next few presentations. So thank you for letting me join, Sahel, Duncan and Sophie.
Thank you very much. Thank you, Jerka. And a lot I've taken up. I loved the fourth shift or the fundamental shift. And that reminds me that is something that is usually we attribute to Aristotle, that the worst form of inequality is to treat unequal people equally. And that fundamental shift from equality to equity, something that we have been advocating and practically trying to do in Bradford District and Craven, and the approach we took in Core20+5 when we distributed the resources and the funding. But definitely, I think this is probably the Center for Population Health. We need to make this this fourth shift or the fundamental shift part of government shifts, because that is absolutely critical. And then I loved it that amongst change there is opportunity, and as leaders we need to make sure that we are taking advantage and we are looking at those opportunities. And the shift to digital and the AI tools of the future, that is so critical. And that is something our academic partners, I think we have a few university partners here as well, and research and development need to make sure that we are taking into account the diversity of our United Kingdom. Brilliant. Thank you very much. I think, Sophie, we are taking the questions at the end of the three speakers in it. Okay, so I will now invite Joe Hobbs to take us through the local Core20+5 journey. Joe?
Thanks, Sahel. So hi everybody, it's lovely to see so many familiar faces, and I can see that there's loads of people here that have joined us today that have been on this journey from the start. But not everybody will know how we got on with setting up Core20+5. So I've had the massive privilege of being the Reducing Inequalities lead in the Reducing Inequalities Alliance, with the job of looking after Core20+5 for the last 3 years. And it feels like a lifetime ago that we set it up. So even those of us that have been part of this journey from the very beginning, I think some of what I will remind us of today will take us back to what feels like a time long ago. So here's the NHS England framework for Core20+5. This was our starting point. This was where we came together. And actually, locally, we added a 6th local priority to the NHS England framework. So you'll see here how we describe our Core20+5 population that Sahel has already done earlier in the session. But we added children and young people's adversity, trauma and resilience to our local programme. This was to shine a light on actually the understanding that we have in Bradford District and Craven of what adversity and trauma can do for our children and the impact it can have on their health outcomes. And actually, when NHS England created the framework, they hadn't yet created the children's framework. So we were kicking off ahead of the children's Core20PLUS5 programme. That meant that we, at that point, weren't party to what NHS England wanted us to do for children. So we added this in as a local priority. And over the next few days, you will hear about how that's weaved itself through our programme. We added in that 6th local priority because we know what adversity, trauma and resilience can do for lifelong health outcomes. So we absolutely wanted to shine a light on what early intervention and prevention can do if we work early in the lives of our children, trying to impact and build that resilience that actually means we can move those children into healthier times. So what did we do? So many are really familiar with how we set up, but actually it is a new and creative way of distributing funding to think about hyperlocal intervention in our communities. So we had some basic principles. These were proportionate universalism. So we distributed our funding on the basis of deprivation. So our district got a variance in their funding depending on how deprived their communities were using the local data. So based on need, you will see again as the week progresses how some areas had more investment than others based on their population. We also wanted communities to make decisions for themselves. And again, you will hear about our community partnerships and the wonderful work they've done to develop the ideas that will make the biggest difference for their community. This wasn't about us in the ICB deciding what it was that we wanted everyone to receive. This was about our communities deciding for themselves what it was that would make the biggest difference for them. We wanted the maximum impact. So what we wanted was to think about how we would do that. So we did want to try and have interventions that were delivered at scale. Again, you will hear about where we have succeeded with that over the life of the programme, allowing for decisions to be made locally, but trying to influence some of them about what might work and what might work best in those communities. We wanted to be able to evaluate the programme so that we could sit here today, 3 years on, and be able to give some of those lessons of what we've learned. That's been a real difficult challenge for our providers, some of whom are grassroots organisations with very small funding, and we've asked quite a lot of them. So those of you that are here today, we are massively grateful for the effort that you put into collecting this information so we can sit here today and share with people over the next 5 days what we feel has worked and what's had the greatest impact. We also wanted to stay focused on prevention. So those shifts that Dirka was speaking about, we know how important it is for the NHS today to think about prevention, to shine a light on what prevention can do, and to think about how we intervene early in the problem to actually try and narrow some of those health inequalities. So we'd laid ourselves a real challenge, and we knew that community partnerships could only do that if we absolutely supported them. So you will see here today are the team that have got the backdrops that advertise our Learning Week. This wouldn't have been possible without the work of the team to support our community partnerships. What we did was we provided them with data, but we also told them about what was already in place in case they weren't actually aware of some of the interventions that were already out there in their communities. We couldn't expect our communities to know exactly about what works. They're not actually in jobs necessarily that are searching through the data to actually think about what health initiatives might make a difference to their population. So we were here to do that for them. And then we were here to help them think about really good planning for what they would do with the resource that we'd allocated them and how they would plan that accordingly. So we'll start dropping into the chat some of where you will find some of the materials, the tools that we have provided, and they're all hosted on our website. But what we started with was a level of guidance for our community partnership. So here we are, we're giving you some funding, but where do we start? So we started with some guidance. We moved on to providing them with data, which actually, as you hear as I go through today, but over the next few days, how much of a difference that's made to our partnerships, where they can see exactly what's happening for their communities. So, of course, they are experts in their communities. They know exactly what's happening for the people that they serve and the communities in which they live. But actually, did they understand some of the health indicators and how some of that was being kind of shared out? And actually how they looked against their direct neighbours on streets that actually weren't that far from them? And what was it that they were doing differently? And what was it they could learn from each other? We also had to build ourselves a theory of change. So clearly we are a drop in the ocean of what we spend on NHS services in Bradford District and Craven. To expect our communities with very small amounts of funding to make massive change by delivering hyperlocal prevention interventions was possibly a bridge too far. So actually what we did, we wrote a theory of change. So based on the principles of what we thought the needs were, what we would like to see over the short term, and what we might then eventually see over the long term. And here we are, 3 years on, we're able to tell you about the short term, and we're still hoping and wishing for those long-term outcomes where we are one contributor into a very large picture. This is a timeline. I can't believe that we've been going for 3 years, but here we are. We started back in January 2023 with that initial guidance. We moved through the planning stages, we moved through the mobilisation of our projects. We then started thinking about monitoring and what it was that we needed to know from our projects. And we've already published some information about how far we have gone and how many people we have reached. We are also planning a next publication where we will be able to tell you about the impact of that reach. So this was the total programme activity so far, and this was back in April. And we absolutely know that in the last 2 quarters since this data was published, we have gone much further. We've stuck to the data that we published for now, but if you join us back on Friday, we will be sharing much more. So there's a little bit of a hint to come back on Friday. We'll share more about what we've learned from these contacts. So we've had over 10,800 contacts, and I absolutely know that's over 14,000 right now as we sit here today. I won't read through all of this, but we have had some really exciting initiatives, and it's not just about seeing people, it's about the impact that you can have. So we know that out of our 893 health checks that have been completed by April, that actually we'd identified 424 that had got an identified health risk, that didn't know before they had come to see us what it was that they needed to support with. But the projects are just one little part of what we've been doing the Core20PLUS5 programme. Actually, the ripples of the programme have been much greater. So we absolutely know that we have had over 70 projects running over the last 3 years, and the work that they have been doing direct with our communities has been massively valuable. But actually the process that we've been through has taught people so much more than how to set up a project and deliver a hyperlocal health inequalities project. The way that we know this is that we embarked on ripple effect mapping. So a year ago, we brought our colleagues together that had been working at that point for 2 years on trying to narrow the health inequalities in their communities. Ripple effect mapping is a really exciting way of asking people what happened and what happened because of that. And what are the intended consequences of the work you're doing and what are the unintended consequences? And we wanted to try and capture some of those unintended consequences. We brought people together. They were largely those people that are chairs of our community partnerships, the deputy chairs of community partnerships, colleagues that we'd worked with in public health and in other partner organisations, colleagues from the voluntary sector who may not be providing a project, but were absolutely instrumental to the delivery of the programme. As you can see from this picture here, it brought about some really rich conversation and therefore some really rich data on what the ripples were of the Core20PLUS5 programme. These are some of the quotes from the day. There were lots of quotes. There was lots of conversation about what the opportunity had brought to the table for our communities that was far reaching from the money and wasn't actually about the money at all, but was about highlighting the issues and the action that could be taken, sometimes with no money at all. It meant that our community partnerships were maturing. It meant that more partners were coming around the table because they were interested in health inequalities and what they could do for their small part in the journey. It was thinking about challenging some of those projects, trying to be braver, move further and faster with what it was that they were doing. And we finally did some thematic analysis from what we heard at our workshop. And we got 8 themes. And you'll hear more about these themes as we move through the week, where partners tell us for themselves what it was that it felt like, what was the feeling around Core 20, as well as what the delivery was like. So we know that we got more governance out in communities where actually in the past they have had funding, but not to this level. And therefore they hadn't had to have the same level of scrutiny upon themselves as we have had to put on them. We also know that it brought about innovation and improvement. So for the first time, community partnerships and the colleagues that they were working with in their local areas were able to think about, actually, can we do something a bit different? Do we need to do the same as we've always done? Because if we do that, we might only ever get what we've ever got. So maybe we need to think about innovation. It brought people together around a common purpose. And actually, it's a real no-brainer when you think about health inequalities. Everybody wants to do something. It's just knowing what to do that's going to make the biggest difference. We probably could have predicted that we'd get benefits to individuals and communities, and that was our intended consequence. We really wanted to see those benefits direct to our citizens in Bradford. But we didn't necessarily expect to see the rest of this. It gave them opportunity to do some strategic planning. The wonderfulness of having 3 years laid ahead of them, knowing that the funding was coming, knowing we weren't going to change the goalposts, and that actually they could really focus on what it was that their community needed. And we know, as Dirka and Sahel have already mentioned, that actually long-term sight at the moment is really difficult. And we often give these communities funding, but it's very short term. And therefore, that's very difficult to plan for. We were doing something a bit different, and communities were really grateful for that. So we learned lots. There's loads more to learn in the days that are coming. We're really excited to share with you. We know that our projects that we have invited along to the next 4 days are really excited to share with you exactly how they got alongside their communities, how they delivered their projects, and what it is that they want to do next. So the next 3 days are really exciting, and then on Friday we will culminate with what we would really hope for the future. Core20+5 isn't done. We're just here to show you in the middle of our journey what it is that we could do more of, but we're absolutely not done here. So there is more to learn. It's just an opportunity to share right now. Thanks ever so much, Sahel.
Excellent. Thank you very much, Joe. And whenever I hear this presentation, there is more to learn. And there is increasing passion in your voice and the way you present. So great. Thank you very much for leading this program of work with colleagues. So now I invite Therese Patchen, our Chief Executive of BDCFT and Accountable Officer for our ICB. Therese?
Thanks, Hale. Thanks. Lovely to join you. And I'm just going to say a few words because I don't think I can top what's been said already. But there's a couple of connections that I want to make, if I may, and then we'll get into questions. So first of all, I have to say thank you. And when you see it all laid out in those slides, Joe, it is just phenomenal what has happened in this place over the last few years. And I think the first thing is to say thank you for all this work, because it's not easy and it's not straightforward, but people have really pushed and worked hard and we can see the outcome. So I want to say thank you. Dirk talked about partnerships. I came to this place 5 years ago now. I've been in this job at the Care Trust, and actually people talked about partnerships with everybody across organisations, voluntary sector, and I don't think I've ever seen it work the way that it's worked here. And we can see that the success of the work has been through partnerships, and we build on that and it goes from strength to strength, and I'll talk about that in a sec. Joe's talked about the hyperlocal, and I want to just talk in a minute about the strategic piece. So when I came into the place lead job in April 24, I said to Duncan and Sahel, and they're probably a bit fed up, I said, population health, what's population health ever done for anybody? Really, what's it done? And Sahel and Duncan went away and did a piece of work, and the first population segment piece of work they did was on palliative care. And actually, when they did that work, fabulous work, and they showed that actually the amount of money that we put into supporting our populations through palliative care, I think off the top of my head it was about 5 million quid. But actually the amount of money that we consume, about 115 million, I think, because our people end up in the wrong place, they end up in the back of ambulances, they end up in A&E when they want to be there, they end up in beds in acute hospitals when they don't want to be there. And actually it shows the disparity of how we're not doing things right. And actually we saw then that if you input at the front end of the pathway with that 5 million, whether that be in care homes or general practice or in palliative care teams, you could really impact not just the output for our people, because actually we don't want people to be dying in the wrong place, but you could really impact on the money. So we've taken that forward, and the question is around how we're going to support BDC in this place. And we have a real issue here because we are overspending by about £70 million a year in the NHS around the money that we're given. And we know that for that 70 million additional, we're not actually getting a good outcome for our people. So what the team did was build on that work, and we developed our Bradford District and Craven strategy, and we started that work just before Christmas, and it is fabulous and fantastic work. I am incredibly proud of the work that the team have done, starting with population health and actually working with a lot of the work that we've done in place over the last few years with our Listen In programs, listening to our people about what would make a difference to them. I hope you drop it in the chat, but we now have a strategy which says, if we really focus on these areas of work, we know that we can make a difference, not just for our population, but for the money that we're spending on that population. Because actually, we've talked about the 3 shifts. We're not going to shift any money into neighbourhood population health unless we address the issue, which is the overspending in acute. So we've got, through the strategy, our 5 population segments where we are overspending. We're driving acute demand, and our people are going into the acute sector when they don't need to be there. And really interesting, the bit that really I struggle to think about actually is what's going to happen in 2040 if we do nothing actually. And we look at the segments of our population who are getting iller. And the bit that I always think about, and I'm looking at you, Duncan, is if you look at that segment at the end, which is the healthy population, if we do nothing by 2040, that segment actually gets less. So actually what we're doing is making our population less healthy, when actually the whole point of our work is to make them healthy. So what we've done now is we've got the strategy, it's in the chat, please have a look at it. It's a phenomenal piece of work, and that is driving the direction of travel for all of our partnership now for the years ahead. We're setting up our governance structure slightly differently. We've got 3 big strategic delivery boards now. One is around acute collaboration, one is around integrated neighbourhood health. And I've said to both of those strategic delivery boards, take your 5 population segments that are driving our acute demand, driving our £70 million overspend, and do something about it, actually. Do something about it, because until we address that inequality and that excess spend, we can't drive the resources back in the front end, whether it be prevention, early help, into neighbourhoods. And that's the work that they're doing. And I'm incredibly proud that building on the work that we've done, building on the work that we've done through our proactive care team, for example, we were successful in getting our neighbourhood pioneer. Lots of people around this room did the work. There was more than 160 bids went into the national scheme. 43 were successful, and we were successful. I had a bit of a conversation with John Oldham actually, because he wanted us just to make sure that our bid was absolutely in the right way that it needed to be just before they were announced. And he said to me, I can say this, can I? He said to me, your bid is phenomenal. It is one of the strongest bids that is submitted. And I know that that is true because it's based on this fantastic work that Joe's just talked about. It's not based on things that we might do in the future. It's based on things that we've been doing together for 3 years. And the issue for us is scale it up. Do it at scale. Don't just do it in certain areas. Make sure that we do it across the whole of our place. So I am delighted actually that we've got the pioneer bid and we can now really do that scaling up piece. You asked the question, I think, about and what happens now in change. We've got the 10-year plan Fit for Future, and actually I think we're really well poised. Actually, some of our neighbourhood work, our population health work really demonstrates where we can make a difference if we focus. And actually, I do think that some of the rigour that we've got around being a neighbourhood pioneer will really help us. And that's alongside the work that Joe's talked about. What we're trying to do in terms of the ICB changes, we've got a difficult time ahead, we've got to reduce our resources, but what we're trying to do with the resources that we've got after the consultation is really focus them on this work. We know this is the work that makes a difference for our communities, and we want that to continue after the consultation and be a real success for the place and the ICB as we carry on. Final question you asked me was, what was my advice? Do more of it, keep on doing it. Follow the data. And I think Duncan and Sahel, when I came in, I said, I don't know what this data has ever done. I think we have real evidence now. And I think the strategy is our start point. If we follow the data, which sits within our strategy, I'm absolutely convinced that we can really make a difference for our population. Thanks, Sahel.
Great. Thank you very much, Cerise. There was so much in that. And thank you very much for your leadership and your support for the work, inequalities and brilliant. Thank you very much. Okay, let's open up for questions. Sophie, do we have any questions in the chat, or anyone would like to put their hand up and ask some question?
Yeah, I don't think there's any in the chat at the moment, but yeah, just encouraging people to stick their hand up and come off mute if they want to ask directly while we've got our speakers here.
Right. Okay. If I make a start then to our speakers and maybe Joe, in terms of your experience, so what were the challenges in taking this hyper-local approach? And what sort of tips would you suggest for colleagues who want to take a similar approach?
Thanks, Sahil. Oh, you could have warned me on that question, but there've been challenges, but that's where I think that's where we've harnessed the learning. So I think one of the biggest challenges is when you devolve that kind of decision making to local communities, you have to support them with that work. I think what we learned really quickly is that our communities absolutely know what they want to do, but actually getting up and running and reaching into those communities that are going to make the biggest difference really does need support behind the scenes. And I think it's a really, really unfair expectation of community partnerships or whatever your local structure is and infrastructure to expect our local communities to understand what works, the evidence, the data, what it is that's going to make the biggest difference. And so I think our learning has been having that background support, quietly supporting communities to help make the decisions themselves. And I think the capacity that's out there in communities, it's there, but it's unfair to expect them to be able to do it alongside, most often, working really hard on projects that they're already commissioned to do. So to layer additional expectation onto voluntary sector partners in the main, as it has been in our delivery, actually needs additional capacity, and it needs consideration of that, because actually the voluntary sector are absolutely golden nuggets of delivery, but are often under-resourced themselves. And therefore having that additional capacity that we put into the Core 20 programme by having reducing inequalities managers in our areas of greatest deprivation, offering proportionate universalism and that extra layer of support. And I don't think we would have got to the point we're at today without that. So I think that's probably one point. We'll share more as we go through the week, but I don't want to do too many spoilers.
Excellent. Thank you very much. We have a question in the chat, but Duncan, first, you have a hand up.
Problems just at the wrong time.
Sorry, Duncan, we can't hear you. Sorry, Therese.
I was just going to answer that question in the chat, start to answer that question in the chat around how community-based inequalities work and better connect with and complement the hospital's efforts. And I need to just clarify that when I talked about the strategic delivery groups, that we've now got 3, they are absolutely multidisciplinary across organisations. So in our acute collaboration work, we've obviously got our acute hospitals, but we've also got the Mental Health Community Trust, we've got primary care, we've got voluntary sector organisations, we've got the independent care sector, we've got local authority. So what we're trying to do is do this work absolutely across our place, because we know that when we get all of our partners together, we get the best solutions and the best outcomes. So that's my start.
Great, thank you. Thanks. Duncan. So you're mute. We can't hear Duncan. So let's go to Derka.
Thank you. So I guess it's interesting. So with NHS colleagues, so there's something about, so sitting on the board of 2 trusts, I think there's an education piece and a raising the profile piece in terms of what is possible, and especially given the immense pressures that our teams are facing in terms of finances and the priorities, it's almost getting the engagement for NEDs and colleagues like that just to help lift that space and go, no, but this is the kind of priority, and creating the conditions. But I guess the other bit is the key bit that you're doing that I'm not hearing necessarily happening across the country. So Therese, I was going to ask you a bit more in terms of the financial picture, because that's what I'm trying to encourage everybody to almost do, is to help make the financial case, because I think that is essential in the current landscape. So I'd be interested to hear a bit more about how you've done that.
Shall I come back into Sahil? So
yes, please,
have a look at the strategy, please, Durka. It's a fantastic piece of work, and we deliberately started with our population health. And when you look at the strategy, the team have done just brilliant work. So we know that when you go through an acute hospital, that's where the biggest spend is, because acute inpatient stays and all the rest cost most money. So actually what they've managed to do through the population health work is see which of the we need to get Duncan in to explain this because he's done work, to see the population cohorts that are driving that acute demand. And we know that by driving acute demand, you're driving and contributing to that 70 million deficit, which is what we've got in our place. Now, when I have conversations, my acute colleagues aren't here, but when I have a conversation with Mel, for example, who's chief exec of our Bradford Teaching Hospital, she says to me about the practice care team, for example. We've known the practice care team for years has had a massive impact on our acute demand, whether that be at A&E or inpatient, wherever it might be. But actually what it does is take maybe 10 people out a week. I don't know, I'm just making the numbers up. And what Mel has said to me is, Therese, that's fine, but you need to start taking 100 people out a week. You need to start taking 200 people out a week. And that's when you start seeing the resources being able to shift out of acute hospitals into the community. And that's why the work that Duncan and the team have done by saying these are the 5 population cohorts that are driving acute demand, focus everything you do on this area of work. And when you look at I was really pleased that when you look at our neighbourhood bid that we put into the Pioneer programme, those 5 cohorts are the real focus for the work. And again, for acute collaboration, I keep pushing, we're not quite there yet, but I keep pushing. These 5 cohorts have to be the work that we do, because until we can reduce those populations from going to the acute, we haven't got the resource. We're in deficit. We haven't got any money to do anything differently with. So that's our real push.
Thank you. Jerka?
Yeah, no, I was going to say it's fantastic. So looking at the strategy, I love the kind of, the level of analysis, but also the more detail you've gone into in terms of these are the principles that we're taking. And so I'm going to share that actually, because I think others, they have, not everyone's got to that level, but I think then that will help the next level, which is then, and the mechanics of the how, because over time it's exactly what we need to do, then shift and reinvest. So don't let it sink, the kind of, but actually protecting it to reinvest and keep pushing leftwards. Sorry, Sahel, go.
That's great. Thank you very much, Jerka. We have a comment. So Shaheen, do you want to come and touch base on some of the projects you're working in BTHFT?
Hi, Sahel, lovely to see you and lovely to see other colleagues who are on the call who I've not seen in a long time. Absolutely, yes. We've got some really good projects which we're getting off the ground, and it'll be really good to perhaps work with some of the people that we haven't worked with, or reconnect with people that we haven't connected with for a while. So Sahel, you're definitely one of them, so we will be finding you. And thank you for everything today as well. It's great.
All right, great. Thank you very much. So colleagues, any other question? Duncan?
Yeah, can you hear me now? Is that better? Yeah, sorry about that. My computer decided to update just as I was going to talk. You can't plan that sort of stuff, can you? I just sort of coming back on some of those points. I think like Therese has mentioned population health work a lot, which has really helped us sort of formulate what the issue is. In a nutshell, we've got about half our population we classify as healthy, about 40% have got long-term conditions, and about 10% fit into that sort of greater complexity. But I think the part of the sort of the key thing about Core20PLUS5 is what it's enabled us to do is to bring in a biopsychosocial model. So to sort of get rid of the long words, basically what we're seeing is that people have multiple health conditions, but also they've got quite complex social lives as well. And giving some power, I suppose, to communities to seed fund some of these projects has given us a greater understanding of where we can not sort of hand over, but trust communities a little bit more in getting the international evidence base, which is what we started with and being data-led, but then putting that with really up-to-date contextual information as well. And I think it's given us a greater understanding of that, and it's given us a greater understanding of what our relative role is. So I think our relative role in the future as strategic commissioners is to provide that oversight and provide those functions that small organisations are just never going to have. But we probably need to go even further with Michael Marmot's proportional universalism. A lot of the things that we'll talk about through this week and the things that we've really found, that a lot of the basics about health coaching, resourcing, health champions, all those sorts of things, that intermediary step between the national NHS programmes and really getting into communities is where the real innovation has been and where really some of the success has been. So I think when we're in a strong position now to take that data-led approach, but also with communities.
Excellent. Thank you very much, Duncan. Any more questions, comments from colleagues? Come on, we have about 70 people. Joe?
Thanks, Sahel. I'm just, Dirka's asking about what might happen next for our projects in Core20+5 and how that leads into neighbourhood development. Oh, Dirk, you're going to have to come on Friday. And if you can't come on Friday to hear Duncan talk about next steps and hear a bit about what we've got from our Reach and Impact report, which is kind of how well have we done and how better off are people because of it, and how we can segue into neighbourhood health, then I'll have to share with you another time, but there's too many spoilers in there to share today. Quite what our thoughts are around how Core20+5 has been a test bed, really, and how if we lose all of that learning as we move into neighbourhood health, it would be a travesty. So we're really hoping that some of those core messages that will drip through the week but will culminate with on Friday move into neighbourhood health, both through the Pioneer project, but then into the fullness of time, what neighbourhood health looks like. I think when those of us that have been involved in Core20, and I'm looking around the room and I'm seeing some of our project providers and community partnership chairs, I think when we saw the neighbourhood health guidelines that came out originally, we kind of thought, oh, that's good. We're in the outside circle. We can see how that's going to work. We can see how what we've learned from Core20 connects the voluntary sector in the main into what we need to be doing that both yourself and Teresa described, and what the future looks like with the NHS long-term plan. So we can see our line of sight. We'll share it with you on Friday if you can join us then.
Thanks, Joe. And Katie has said that she will be joining on Friday and interested in hearing what is happening with the projects, especially the maternity circles. So that'd be great. Duncan?
Yeah, just really quickly, one of the models that we've been really influenced by in this work is the King's Fund 3A models. So what's our awareness of inequalities? What's our action about inequalities? And then thirdly, what's our advocacy? And I was really struck by what you said there, Dirka. And I think we sometimes don't make enough time to share what's going on. So this is about Bradford today, but we work part of a West Yorkshire ICB. That's 2.5 million people. We work as part of a national system of communities and ICBs as well. So I'd be really keen on learning from you about whether it's blogs or whether it's video diaries or however we can share from the small right up to the strategic messages, because what Sophie's been doing during the last 2-3 years is going and getting the stories, and it's that action and advocacy bit from our 60 or so Core20 projects. And we've got loads of great stuff on the website. And one of the things that we wanted to try and do with the wider inequalities work is demystify inequalities. I think the challenge is so great. One of the things that we can do is really get people to think about what's the action they can take in their workplace. Doesn't matter if it's an individual team, an individual surface, but it's that thousand flowers analogy. We've all got a small part to play in reducing inequalities. So just really interested in continuing that discussion after this week.
Brilliant. Thank you very much. Thanks, Duncan. Sophie, we are approaching towards the end. Do you want to just say a few words around the next 4 sessions and just briefly what will be covered in those and the timings, etc., if people would like to join?
Yeah, of course. I've just put the link for the whole week in the chat, and just to mention, Eventbrite limits our ticket sales, so some of them say sold out, but we can still invite you. If you just email Ria, we will send a calendar invite across. So the session that we have tomorrow, it's first thing, so we've tried to stagger all the times. It's at 9 AM. And this will be a focus on the Core20 aspect of Core20+5. And it's around how the projects have made the efforts to reach those that 20%, so the most deprived households in Bradford District and Craven. And then we're going to be hearing throughout the week from different projects and partners that have their projects and what they have done to address this. So how we increase access to healthcare for those that we aren't reaching at the moment, and the different ways of engagement that we haven't used in the past. So that's tomorrow. Then the session on Thursday is 3 till 4. That focuses on the plus aspects of Core20+5. And that is about improving healthcare for our marginalised groups, or we sometimes call them inclusion health groups as well, which was mentioned a bit earlier. These are the groups marginalised from health services, the worst health access, experience and outcomes. And again, we'll hear for some projects from that. And Thursday is the 5 aspect, which is around the clinical outcomes that were mentioned, the 5 different clinical outcomes. So there's, for example, cancer is included there, maternity is included in there, mental health conditions. So yeah, those are the areas that have the greatest healthcare inequalities, and we'll share our learning again from projects. And then finally is Friday, which will wrap up the week. That session is at 10 a.m. and they're all an hour, all online. And that's just like what Joe has already mentioned, just wrapping up everything from the week. What's next, what Dirk was asking about, and our plans on how it will fit in and align with the NHS long-term plan. So those are all on the Eventbrite collection. Please do sign up or email. Yeah. And we'll also be recording this session, so if you can't attend, they'll be on our YouTube channel, which will be sent out via our newsletter. So if you're not signed up to our inequalities newsletter, please do that, and I'll put the link for that in the chat as well.
Brilliant. Thank you very much, Sophie. So, well, thank you very much, everyone, for joining. Thank you very much to our speakers. Thanks, Turka, Therese, Joe, all the team, everyone working in Bradford District and Craven who have worked on inequalities, healthcare inequalities, and continuing to work on that. I have taken that 4th shift, Dirka. We will be proudly talking about, not equal but equitable. And I have been in commissioning land for about 10, 11 years now, and we still it's getting much better, but still hearing these questions, these things about, well, why should we invest in tackling healthcare inequalities or health inequalities? Why should NHS invest in prevention? Is this our job? Is this public health job? Is this council job? Where does our job stop? Where does someone else's job start? Surely we have services for people. If they don't attend, then it's their fault, isn't it? We have services for people. Why are they not attending? So I think the answer is, it's not just the theoretical, ethical, academic answer to all this. The answer is quite financial. The answer is that NHS will not be able to survive in the next 10 years, and we will not be able to deal with demand if we do not invest in prevention in its broader sense, but also the targeted prevention that we can do, and we will not be able to meet with the demand if we do not invest in that. And for that, the NHS, the health inequalities work has to come out from a nice to do box to a must do box. I've always said this, it's not a nice to do thing, it's a must do, it's a survival for the NHS. We have to look at prevention and we have to invest in inequalities, and these two things are not synonymous. We can prevent people, but we can still widen health inequalities. So we need to do both. So from today, think equity, think Core 20, move from presumed equal, as Dirka said, to tackling inequality when we are looking at data, when we are planning services, when we're doing research, when we're allocating resources, and please continue to be the inequalities ambassador in Bradford District and Craven and beyond. So thank you very much, and we'll see you tomorrow now at 9 o'clock, Sophie, isn't it? So thank you. Thanks, Dirka. Thanks, Therese. Thanks, Joe, Duncan, Sophie, everyone. Thank you very much. We'll see you later. Bye-bye.